Welcome to the Consortium of Universities for Global Health webinar series, and we have a fantastic one for you today. I'm Dr. Keith Martin, the Executive Director for CUGH based here in Washington, D.C. This webinar is part of an ongoing series of webinars that we will offer up during the course of the year, and it's really to acquaint you with ongoing global challenges and, importantly, how you can get involved to address them. Today's webinar will be on sepsis, an incredible neglected global killer that affects more than 30 million people a year. And we have two outstanding international leaders in the fight to address this global killer. Dr. Tex Kissoon is a professor of critical care and global child health at the University of British Columbia. He is also the vice chair of the Global Sepsis Alliance. Dr. Ron Daniels is the CEO of the UK Sepsis Trust and clinical advisor of sepsis to the National Health Service in the United Kingdom. He is also the CEO of the Global Sepsis Alliance. If you would like to get involved in CUGH, know more about us, please take a look at our website at www.cugh.org. So it's a great pleasure for me to hand over to Dr. Kissoon in Vancouver, who's going to talk a little bit about the problem of sepsis and some of the pathophysiology around that, and Dr. Daniels will take over after that. Dr. Kissoon, you have the floor.
Thank you very much, Keith, and I really appreciate being here. As you mentioned, sepsis is a neglected global killer of enormous proportions. And indeed, having worked with my adult colleagues, and you will hear from Ron Daniels also, my background being pediatrics, it affects citizens across the world from many different backgrounds, both adult and children. The fact is that we said it's a neglected global killer because although sepsis has been known from the days of Hippocrates, what sepsis basically is not very well known to the public, as you will hear, but it has enormous implications and affects large number of people for a variety of reasons. So for the next few minutes, what I'd like to do is spend some time discussing with you what is sepsis. I would like to then challenge you to see the disease as a multifaceted problem in which multifaceted approaches are needed, and then speak a little about the need for advocacy because, as we said before, it's neglected and it's of a major public health crisis. My colleague Ron will then tell you some of the issues and ways to get involved and the projects that we are doing to rectify and change this. So as members of the Global Sepsis Alliance, having worked in this area and studied sepsis for many years, what we have found is that sepsis as an entity, a syndrome, does not belong to any one clinical entity. It affects everyone, patients across the board, and hence, while it does not belong to anyone, it has not found a home. But in simple terms, while there are many different ways of defining sepsis, sepsis can be caused by any serious infection that leads to multi-organ dysfunction. So if we look at the major killers in the world, it will be pneumonia, diarrheal diseases, and malaria will be listed at the top. But there are bacterial sepsis, dengue, mixed infection, nosocomial infections, HIV. But the common feature of all these infections, if they are severe enough, they will lead to multi-system dysfunction. They may lead to myocardial depression, anemia, thrombosis, endothelial dysfunction, kidney failure, CNS involvement. But the multi-organ dysfunction will lead to death if not recognized early and if not reversed early. And this is the crux of the matter worldwide, where we are trying to work with major societies and colleagues to recognize this commonality of major infections under the rubric of sepsis. Now, this is an enormous task, and we need everyone to be involved in various ways. Now, this is these are data from the global child deaths showing under 5 mortality in children. And if we look at the under 5 mortality, many of it is due to malaria, a large proportion, malaria, diarrheal diseases, lower respiratory infections, measles, AIDS, and some other infections like tuberculosis. But these diseases are classified under either an etiological or system involvement. But we would argue that most of these diseases, if they are going to lead to death, will be sepsis, because there would be involvement of many organs in the body and ultimately death. So the percent of these attributable to sepsis is very high. And we have had recent discussions with the Global Burden of Disease team to enhance the data by identifying this as sepsis. And we will see the reason why. If we look at the National Institute of Health data of the top 10 killers, emergent and re-emergent infectious disease, again, a large proportion of those, if not most, will be due to sepsis. Now, but we don't really know the exact burden. This is a review recently that is now under consideration for publication that was done looking at adults worldwide to determine the burden of sepsis. And one can see from the map there are areas in the world, usually in resource-rich areas like Europe, North America, and Australasia, where data was available. There were some data in other, patchy data in other areas of the world, but data from most of the world is not there. And these authors, Dr. Fleischman and Reinhardt and their team, estimated that there are over 30 million cases per year. They feel also that this is this is an underestimation of the number of cases, because that to some extent assumes that there's infrastructure, treatment, the same sort of context in different parts of the world. But we know that the majority of people in the world have less resources, and the outcomes are going to be poorer in many parts of the world, especially in sub-Saharan Africa and in Asia, where the bulk of the world population are. So the data that we have represents about 15 to 20% of the world population, and the estimates are going to be a lot higher. And there are about 8 million deaths from sepsis. So it's an enormous burden of disease that we see. There are several reports that have come from various parts of the world, even in the past year. Most of these reports were within the last 8 to 10 months. And it shows that the incidence and mortality and morbidity are unacceptably high worldwide. In the United States, reports have shown it. We have done studies in China and Canada showing the very same thing, and the Australasian group has done it, India and Europe. So it is very high in children, and the data from the adults that I just referred to has shown it is unacceptably high both in the adult population. One of the factors also that puts the burden into context that has not really received great press or has been highly publicized is the late mortality. That's after discharge. The morbidity also is very high, and the morbidity in the adult population has been publicized, and I think Ron may mention some of that. But the late mortality in children, this is some work done by my colleague Matthew Weens, who just received his PhD, and looking at different areas in Africa. And one can see in most cases there's the inpatient death. You can see the grayish sort of bar, but the bluish bar you can see post-discharge death are higher in many areas of the world, and most of these deaths are occurring within 3 to 6 months of discharge. There is one report from the United States, Washington State, that showed an equal number of patients died post-discharge over a few years, but these are acute deaths. And what is worrisome in this case also is that many of these patients, at least a third, does not return to a health facility when they're sick. If we look at the global burden of life years lost, disability and life years lost again, we can see that most of it is due to infectious disease, lower respiratory infections, again pneumonia, malaria, sepsis, and other diseases of the newborn, typhoid fever, whooping cough, etc. in that led Matthew Bond at Harvard University to say that infectious diseases systematically steal human resources. So the importance of identifying sepsis is that it is a compelling public health issue. And the fact is that most cases of sepsis, regardless of etiology, presents with similar signs and symptoms, danger signs. Most interventions to reduce sepsis has to be made before final diagnosis in generic terms. Many healthcare workers have limited training, and time-sensitive treatment will not happen if sepsis remains siloed in the individual diseases, because then it becomes, protocols become a little more complex for those with limited resources in limited areas. So when I speak about a multifaceted problem, I think it depends on context. And as this Clayton Christensen, his book said, in developing countries, the notion of replicating systems of the developed world is unthinkable. Their only option seems to be adequate care for the rich and little for everyone else. And I think we see that in sepsis. And one of the major issues in sepsis, I think, worldwide is the lack of resilient systems. When I say resilient systems, the resilient systems are very important, and resilient systems is really outlined by Ebola, where what we're showing here is that Ebola is decimating local healthcare workers, depleting blood banks and essential supplies, and all this means dangerously reduced healthcare services. Indeed, this leads to destroying trust in the healthcare system, and as Margaret Chan of the WHO said, this can all be answered in one word: poverty. So the fact is that there are systems in the world that are not resilient, mainly because of this issue. Now, the other issue that, that faces us very clearly in sepsis is the fact that if you look, things are getting worse for children, and children in low-income countries are now nearly 18 times more likely to die from sepsis under the age of 5 years versus high-income countries, whereas the mortality rate was 14 times in 1990. The fact is that sepsis has due to several issues. It's a socioeconomic problem, as I said, with education and money playing a role, distance and unavailability of transport, many stops and wait is along the system, and the fact is that those lead to poor seeking behavior. It's also a clinical problem where there are unique burden of disease in developing countries, and the etiology varies, there are low immunization coverages, and comorbidities are prevalent, and there's delay in recognition, basic procedures not being followed. At the same time, there's low emphasis in many countries on preventative services. The fact is that they are poorly regulated and managed health sector systems. New drugs for tropical disease are not being developed at a rapid enough rate, and in many cases the developing world is being robbed of healthcare staff. So a multifaceted approach is what is needed for this disease. And what we say when we say a multifaceted approach, we need to look at preventative measures, for instance, vaccination, strict hand hygiene, etc., addressing nosocomial infections, early recognition and aggressive treatment, rational use of antimicrobials, innovations in care, and then look at knowledge translation, capacity building, and advocacy. Now, one of the things that we know that there are elegant sort of demonstration of prevention working is, as we know from the Broad Street cholera epidemic in 1834, John Snow, an anesthetist, recognized that the cholera outbreak was due to water being pumped from the Thames River to certain taps. No one would believe him at the time, and he removed the tap handles and the outbreak decreased, showing the power of prevention. There are other factors that come into play. Obviously, there's the UNICEF data showing that as the longer that women stay in school, mortality rate for under 5 mortality for children decreases. I think that's a proxy for obviously education and wealth, and public health policies of vaccination days, national health weeks, oral rehydration salts, and nutritional programs have made a difference. In addition, in many parts of the world, because of the difficulty in getting to healthcare systems, provision of low-cost antibiotics to child health workers in daycare and clinics has reduced neonatal mortality in Pakistan. And in several areas of the world, given drugs and simple tests to child health workers have reduced drug overuse and increased early treatment for pneumonia and malaria. Also, strengthening skills have led to better health-seeking behavior. In addition, we have crafted guidelines for treatment of sepsis in low-resource countries, in which we have classified areas into where management in which there are few resources, areas in which there are some resources, in which there are considerable resources, and standard of care for developed countries. But ultimately, in most areas of the world, in low and middle income countries, we need to build capacity. And building capacity entails increasing community engagement, strengthening competencies at all levels, adapt guidelines based on available resources and current evidence, using innovative technologies, transport and referral systems, and evaluating the impact of intervention and sharing those interventions in a very collaborative manner. So based on these data, we have looked at the issue of sepsis across the world, and based on the child mortality data of greater than or less than 30 and the developed and developing nation and resources that are available, we have given guidelines. So in low areas in which child mortality is very high, immunizations, potable water, nutrition, zinc supplementations, IM antimicrobials may be very useful, while as more resources come into play and child mortality decreases, the use of oxygen, intravenous fluids, nasopharyngeal, CPAP, and emergency clinics come into play, and then we come into the developed and developing world where we can have modern ICUs and extraordinary support that we have. Ultimately, in any area of the world, anyone who chooses to adapt guidelines will need to look at resources, level of care that can be given, and then have feasible steps for management and feasible steps for monitoring. We also need to address the impact of antimicrobial resistance, and this is a major issue that we are now dealing with, and the World Health Organization has really taken the lead on this to really look at the rational use of antimicrobial agents, because in some cases there's rampant use of antimicrobial agents when they should not be used, leading to multi-drug resistance. The issue of the maternal issue is one that we need to address in many parts of the world, because maternal mortality is still very high during the perinatal period from sepsis, and if a mother dies, her child has her newborn has an 80% chance of being dead within a year. Post-discharge survival is also an area that we have been concentrating on, and my colleague Dr. Weens has been from the Grand Challenges of Canada, has been looking at a mobile app that gives some information that is linked to a child health worker referral and a discharge kit that will be used. We are doing a pilot project in Mbarara in Uganda, but in many parts of the world we think that we can leverage technology to better outcomes. And finally, I think we need to increase awareness, and I think Ron will speak more of increasing awareness. There are many campaigns, the Clean Hand campaign, hand hygiene, 5 moments of hygiene, we need to learn a lesson from these campaigns and improve in our own area of sepsis. Indeed, Sidney Farber around 1950 recognized for cancer, he said a campaign for a disease is much like a political campaign. It needs icons, mascots, images, slogans, the strategies of advertising as much as the tools of science. And for any disease illness to rise to political prominence, it needed marketing. A disease needs to be transformed politically before it could be transformed scientifically. A very good example was polio, in which the March of Dimes was formed in the United States. And as Bill Gates said, he was fascinated by reading this book, American A Polio Story, in which that the March of Dimes used famous actors to get the message over, but also introduce the idea that millions of Americans, not just the wealthy, could play an important role in helping solve big problems. The bottom line was the National Foundation for Infantile Paralysis turned polio into America's #1 health threat. It was uniquely dangerous in their mind, but it was beatable. And in 1954, of $140 million raised in charity, about half went to polio, despite 100 cases only, as opposed to American Heart Association and the National Association for Mental Health, who received small amounts of money for 10 million cases each. We are not doing a good job at the present time in vaccine. We know there are many outbreaks of vaccine preventable diseases which lead to sepsis worldwide. For example, measles, whooping cough, mumps, etc. But the power of politics, religion, and celebrity have played into this, and indeed, advocacy groups against anti-vaccine advocacy groups have been very active. What we need to do, despite the use of major Hollywood actors, Jenny McCarthy, Jim Carrey, Donald Trump, etc., we need to understand what parents need. And as Eula Biss in her book said, at the heart, the anti-vaccine movement isn't a product of ignorance and selfishness or even fear, although some of that exists. Jennifer Wright, sociology at University of Colorado, spoke about neoliberal mothering. And I think that we have to engage parents now because they're asking questions and people are asking more questions of us. We need to educate them. And finally, as I said, that through the Global Sepsis Alliance, we'd like support worldwide for World Sepsis Day, and you can go on the website and join. I think that I hope I've been able to convince you that this is a major problem, and as David Lloyd George said, don't be afraid to take a big step as one is indicated. You can't cross a chasm in 2 small jumps, and we owe it to our patients worldwide. So I'd like to thank you very much and hand back to Keith and Ron.
Thank you very much, Tex. That was a fantastic overview of sepsis. I think that's a wonderful lead-in to what Ron's going to talk about. And for those online right now, Dr. Kassoon's slides will be available online. We'll post it in the days ahead. And I apologize for some of the technical difficulties we've had. But I think that's a great segue that Tex spoke about the need for political action. And both Tex and Ron are part of a Global Sepsis Alliance, which you can actually look on. If you look at Global Sepsis Alliance, please check out the website. There's a lot of good information on there and what you can do. So it's my great privilege to again introduce Dr. Ron Daniels, who's coming to us from the United Kingdom, and Ron is the CEO of the Global Sepsis Alliance. Ron, thanks for joining us, and you've got the floor with your slides.
Thank you, Keith, and it's a privilege to be able to talk to you all and to follow my good friend Tex. As Tex said, we're leading into now what we're trying to do within the Global Sepsis Alliance and the World Sepsis Day movement in order to effect change. And it absolutely has to be about campaigning. Science is not enough. We can publish as many papers as we wish, but we know from history that this won't impact in transformational change. And we need large-scale change to save the number of lives that we can save. So we've got to brand, we've got to market, we've got to better understand how to run sepsis as a business, We've got to engage our politicians and governments, but just as importantly as all of that, we've got to talk to the average man, woman, child on the street. So, first of all, I think we have to remember this is about people. This is about the narrative. You listen to a president of the United States, for example, delivering a speech in public, and he uses this tool, the narrative. Makes it personal, makes it about himself. So let me have a little go at this. This was the straw that broke the camel's back for me. This is Jem on the left and his wife Karen on the right and their children Tom and Emily. And the photo is grainy, and I make no apology for this because there are no more recent photos of Jem because he died from sepsis 2 weeks after this photograph was taken. And it wasn't me watching him die, it wasn't me walking into my high-income country intensive care unit and seeing all the machines and the pumps and the drugs we were giving and the equipment we was benefiting from. It was the emotion. It was looking at Karen, looking at this devastated wife holding her husband's hand, knowing that opportunities to intervene to rescue Jem have been missed in the community, been missed in the interface between the community and hospital services, and being missed in my hospital. And the moment that brought this home to me that I had to act was when I was walking down the hospital corridor following Karen, about to take her into an interview room, and knowing that I was about to take this young woman and to tell her that her fit, strong husband wasn't coming home, and that she was going to have to go home and tell Tom and Emily that Daddy wasn't coming home, and all from this condition they'd never heard of. Now, these opportunities to rescue we missed in secondary care in an affluent country, in a country with a proud National Health Service. And if we can miss it, that means that every day, every minute of every day, it's happening out there in other countries. And it's getting worse. Sepsis is on the increase. We know data from the Centre for Disease Control shows us that sepsis incidence has been rising by between 8 and 13% every year over the last decade. That's enormous. And part of it is better recognition, which we welcome, but part of it is aging population, increasing crowding, perhaps in some countries reduced uptake of vaccination programs, perhaps inadequate hygiene, inadequate sanitation contributing to this. But unlike other killer conditions, acute myocardial infarction, many of the cancers, not only is the incidence rising, but also, unlike those conditions, the mortality as yet is failing to fall. And that's what we're going to fix. This is a UK Premiership football club, or soccer club for those of you in the United States. And this particular stadium is my local one, and it holds 37,000 people. And 37,000 is a very conservative estimate of the number of people who die in the United Kingdom. So give or take a country of a population of 50 to 100 million population, this is about the number of people that are dying from sepsis every year. And these are not just faces in a crowd. We have to remember these are people with stories to tell, with lives to live, with people around them who love them. Now, the stand I've highlighted in pink, we call that the North Stand, that holds about 8,000 people. And to put this into context, that's about how many people are dying of breast cancer every year in the United Kingdom. And it's right and proper we continue to strive to reduce those deaths. The Trinity Road stand there in grey, that holds about 14,000 people, and that's about how many people are dying of bowel cancer every year in the United Kingdom. In the developed world, sepsis is claiming more lives than breast cancer and bowel cancer and prostate cancer and HIV and AIDS and road traffic accidents put together. This is a devastating and enormous problem, and it is of the utmost urgency that we work together to fix this. Tex has already alluded to this. Data from Conrad Reinhardt now estimates that it's more like 30 million people every year worldwide are developing sepsis. We're seeing 8 million deaths, and we're seeing 19 million survivors. And a huge and disproportionate number of those deaths, and Tex is far more expert in this than I, and has alluded to it, are in children. And as Tex has also said, deaths in pregnant women. In the developed world, it is, certainly in the UK, the most common direct cause of maternal death. And it's something we can help to fix. Again, we've alluded to this. Some people survive sepsis, and we in healthcare, certainly in the developed world, might celebrate, but we're too often wrong to celebrate because, yes, some people, like this individual who's a singer from the United Kingdom, some people return to what for them is normal function. but many aren't so lucky. Even in developed countries, many have long-term cognitive impairment, as this slide suggests. In about 16–17% of people, around 22% of intensive care unit survivors have post-traumatic stress disorder, and that doesn't count the innumerate people who go through months or even years after surviving sepsis a shadow of their former selves, unable to function at their previous level, through fatigue, through myalgia, through psychological disturbance, through anxiety, sleep disturbance, etc. Sepsis has a huge fiscal burden, which we're only just beginning to understand and to measure. For me, whether we're in sub-Saharan Africa, whether we're in the rural plains of Bangladesh, whether we're in the UK, it's all about recognition. And some of you will know that we're about to see some new definitions for sepsis. And I have to say, personally, as someone championing change, these new definitions concern me. We would all recognise that this gentleman was sick. This slide is with permission, as with all my photos. This is a sick patient. He has purpura fulminans, he had a very low blood pressure, and our healthcare system, certainly in the UK, would not fail to spot him. The people we fail to spot are more subtle, and the new definitions are going to identify, I fear, a very sick cohort of patients. Now, these definitions will be robust within hospitals. They will predict who needs to go to critical care. But for the rural practitioner in a resource-poor country, even for the community practitioner, the general practitioner in my own country, they're going to be of limited use when faced with the person who, yes, has an infection, but is starting to show signs of abnormal physiology. These people need to know which patients to send to hospital, and the new definitions, I fear, are not adequately going to address this. We assume that sepsis starts as an infection and progresses through general inflammation, which we currently use to term the systemic inflammatory response syndrome. And when the two come together, that denotes sepsis. We suspect that if we don't treat that, then patients will inevitably slide down. They will develop organ dysfunction, which denotes severe sepsis, and ultimately multi-organ failure and failure of the circulation or septic shock. Of course, this is slightly simplistic because we don't know that this is a continuous spectrum for every patient. We have lots of evidence for intervention on the right-hand side of this slide, the deep pink there, the septic shock, and a similar amount, perhaps slightly less evidence in the severe sepsis. And it's important we have evidence there because these cohorts of patients respectively have mortalities in the adult world of 50% and 30 to 35%. So these are entirely sick cohorts of patients. So what do? We build guidelines based around these cohorts. And your shop floor clinician and your shop floor nurse and allied health professional thinks, well, what I'm going to do is intervene at the light pink. I'm going to intervene when a patient has uncomplicated sepsis, because if I do that, I'm going to stop them deteriorating severe sepsis and septic shock. And we can't say that's wrong. What we can say is we don't have evidence to support it. We know that in septic shock, for every hour we delay, the risk of death increases by 7.6%. And that's a hugely important message to take to governments, to take to commissioners, to take to policymakers, because they then know that if in the developed world, for example, a patient's recognised in the community, but there's a delay of an hour or 2 hours before the ambulance arrives, and then the emergency department won't assess the patient for another 3 hours, then we've subjected the patient to an increased risk of death. We know that it can be done. We know that we can get it right. We know that this was an organisation across 11 hospitals in North America with a robust and continuous sepsis programme showing their mortality reduced from an already very good 21% down to just under 9%. Now, I'm not suggesting we can affect this worldwide, but if in my country we get mortality down from its current level of 30% down to 20%, then just in the United Kingdom we'll save an extra 12,000 lives every year. So it's got to be worth trying to affect change. And some of you will have seen this from Stanford University, some very exciting work where they've identified almost a genetic blueprint for the evolution of sepsis. They've identified that when certain genes are expressed, this denotes that sepsis is about to occur. And that's great, but it's not going to answer the problem. Because if we look at the number of receptors, the number of cytokines, the number of gene expression molecules that are being evaluated at the moment, we see over 170. Now, not one of those anyone is suggesting is going to be the answer on its own, but a biomarker panel is only going to be of utility to patients if it can be measured. Now, in resource-poor areas, we know it's extremely unlikely that's going to happen. I can tell you now that in many developed countries, that's not going to happen in the community. Where tests like this might help and where they might inform future change is testing them in high-risk patients, perhaps post-operative patients, etc. But beyond that, they're not the solution to transformational change. We've got to remember, and this is now how we start to engage governments, how we start to drive change, that this is about people. This is Rianne with the dark hair and Manuel with the fair hair. They didn't know each other until the day this photo was taken. And this was taken on the terrace at the Houses of Parliament in the UK. Rianne lost her mum to sepsis and Manuela her husband. And Sophie, Manuela's daughter, lost her dad. We need to get people like this to talk about their stories, to talk to journalists, to talk to the media, to talk to politicians and government, because until they see the human side of the story, facts and figures will not affect change on their own. So what about public awareness? Well, we know that sepsis is more incident than stroke, than heart attack, than cancer, and certainly far more incident than HIV and AIDS. And then we compare that with the public attention that's delivered to those. So we set out in a number of countries to examine this with a public awareness poll, which we standardise across the countries. And Germany, where there's been a fairly mature sepsis campaign and visualisation of sepsis on a major soap opera, 49% of the public had heard of sepsis. In the USA, slightly less good. But then down in Brazil, 7% of members of the public had heard of sepsis. And until that changes, we're not going to see governments acting. We've done this in the UK, and we found we're similar to the USA. About 40% of our population has heard of sepsis, but of those, only 40%, so 16% overall, know that sepsis is a medical emergency, and we've got to change. As Tex has said, it's not all about adults, it's about children as well, and children are an incredibly powerful influencing tool. Of course, every child death is tragic. I have 4 children myself. I'm not talking about this in a detached fashion. This is Tilly. Tilly was a young infant when she developed sepsis. She'd had chickenpox. Initially, her mum didn't know what was going on. She thought she was deteriorating with chickenpox again. But she got worse and worse, and Tilly's mum took her to hospital, again in the UK, whereupon they didn't do a lot to start with. They said, well, keep an eye on her. And Tilly was saved not by clever machines or professors. Tilly was saved by the most junior of healthcare professionals in the UK, a healthcare assistant. And the healthcare assistant was measuring Tilly's observations, and she knew Tilly was getting worse. And she said to Tilly's mum, I'm really worried about your daughter. I think she's getting worse, but they, as in the nurse, the doctor, the consultant, they're not doing anything. So Tilly's mum put in place a chain of reactions that led to Tilly's successful survival, so that Tilly's now a happy and healthy identical twin sister to Lucy. It's about people. And when we make it about people, we can get policymakers, commissioners, governments, and hopefully in time, the World Health Organization and Assembly to listen. NHS England have now begun to listen to us. They've issued a patient safety alert with a suite of resources. They've started investing in sepsis change. And this is not all about the UK. It's using the UK as an example as to how we can affect change in other countries. So we're investing in the UK around £250 million over the next 3 years, incentivising healthcare organisations to do sepsis better. So we've got an improvement metric and we've got a commissioning framework so that if organisations deliver better care, if organisations in this example screen for sepsis, identify sepsis reliably, and then deliver the most basic elements of care, the intravenous antibiotics for a resource-rich country, then they get financial incentive, they get additional reward. And this will help to drive change, but it's only going to be a small part of it. The next step, the next thing we're taking to politicians is the need for data. We need a data registry. And we would urge other countries, and the Global Sepsis Alliance is urging other countries to build data registries. And in time, we hope that these will merge into one global registry, so we can understand not only how we're improving outcomes for people with sepsis, but also what the long-term human and fiscal burden of the disease is. Tex has alluded to this. We need to change the public perception around antibiotics. We need to stop them being used. This was from Public Health England, who've got it. Public Health England now accepts that the very reason we need to preserve antibiotics is not to undertake elective operations safely, because frankly the risk of infection following elective operation without antibiotics is not that much greater than elective operations with antibiotics. It's so we stop people dying from routine infections like pneumonias and urinary tract infections, which of course will lead to sepsis. We need to educate our public. We need to educate them as to what the signs and symptoms in lay terms of sepsis might be, so that if they're at home suffering, if they're at home with a chest infection or symptoms of a UTI, then they know what to look out for. So we're starting to work with GPs and pharmacists to educate patients on sepsis. The challenges in resource-poor areas are enormously greater because we've got not only an educational change, but also a cultural change in terms of accessing healthcare. We're providing leaflets and booklets to post-operative patients to identify high-risk groups, and primary care has to play a part in this. We have to get family practitioners, general practitioners, and community services on board with this. As we move forward, we need to work with the media. We need to start selling stories. So to sell a story to a newspaper, to sell a story to a television crew, is not about we've published a paper, this is really important. It's about we've published a paper, this is a comment from a higher influencing politician, and this is a case study to go with it to make it about humanity. Times are changing. The government, as I've said, in the United Kingdom is now investing, and governments in other countries, in Brazil, in Germany, in the Philippines, in Turkey, in the United Arab Emirates, and in the devolved countries in the United Kingdom are now acting and are now investing. So we're starting to see a global sea change for sepsis. We're starting to see people putting on events, healthcare professionals putting on events outside their comfort zone, not just conferences, not just meetings, not just academic discussions, but marches on government, rallies, public-facing events to spread the word. This was in Nepal. And across the Global Sepsis Alliance, with our World Sepsis event in September every year, we are seeing increasing numbers of events. Last year we saw more than 200 events in 60 countries around the world across all densely populated continents. Healthcare professionals are interested, the public are becoming interested, and we're starting to see an appetite for change. So the next step for the Global Sepsis Alliance is securing World Health Assembly endorsement for World Sepsis Day. Now that sounds like nothing. That sounds like it's simply a rubber stamp, but actually it will achieve so much more. We can continue putting on World Sepsis Day, but without endorsement, it is just a stunt. With the endorsement, it will be linked within the World Health Organization strategy tightly to infection prevention strategies and antimicrobial resistance strategies. Member states will be asked to resource the raising of public awareness. They will be asked to improve access to the basic aspects of care and to examine their healthcare system's needs. We will start to see more and more registries coming out so we can understand what's going on, and we will start to see greater funding allocated to research and development. But most importantly, we're going to see people talking sepsis and raising that public awareness so that sepsis can become a household word. And if it becomes a household word, people will access healthcare sooner. So just to remind you what this is like, and you can upscale or downscale this according to the population of your region. Remember, this is for about 67 million people. So we're seeing 37,000 deaths. If we get this right, just by delivering the basics of care, intravenous or intramuscular antibiotics, intravenous fluid challenges or rehydration salt, then we can save lives. And we can save a third more lives, as many in my country as 12,500 to 14,000 lives every year. Globally, 2 to 3 million lives can potentially be saved every year. I'm going to leave you while we're signing out and returning to questions with a short film. It's only 60 seconds, and it just shows how this has a global impact.
Mein Name ist Mark. Ich habe 2012 meinen besten Freund Martin im Alter von 41 Jahren durch eine Sepsis verloren.
Ni Luba. Na damu da rashin ‘yata Zainab, ‘yar kwana 5, dalilin cutar mugunyar jini, watanni 7 da suka huce.
Меня зовут Игорь. Моя сестра Анна умерла от сепсиса, который явился результатом пневмонии. Ей было 58 лет.
Meu nome é Maria. Em 2012, perdi meu marido violado de sepsis. सुमन के पापा सेप्सिस के कारण चल बसे जब
मैं पापा को बहुत मिस करती हूँ।
My name is Patrick. I contracted sepsis aged 9 months old, and as a result, I lost all of the fingers on my left hand, the second and third digits on my right hand, and my right leg below the knee. But I survived. Stop sepsis, save lives.
Thank you. Patrick is an absolute legend.
Thank you very much, Ron. That's a really poignant and powerful way to enter into our questions, and you really followed on to what Tex spoke about. You really put a human face onto this disease. It's not about the science, as important as that is. This is about people being snatched in the prime of their lives from those who they love and who love them. So thank you very much for doing that. We've got some really fabulous questions in front of us, and I'm going to repeat the question and give it to one or both of you. The first question is, and I'll ask either of you to respond to this, can you discuss the role of checkpoint inhibitors in sepsis and the potential role of identifying decreased host defense and anti-PD-1 and anti-CTLA-4 and sepsis? So either Tex, Ron, if either of you would like to take that on, please go ahead.
Sorry, the role of what inhibitors?
The role of checkpoint inhibitors in sepsis.
In general, when we look at magic bullets for sepsis, including inhibitors of any form or shape, we have not been very successful because sepsis is a very complex syndrome. And once we look at it, once you get beyond the simple treatments that Ron spoke about, antimicrobial agents, given fluids, given some oxygen and supportive care, we have not really made great inroads. And in fact, many candidate inhibitors have been suggested over the years, anti-tumor necrosis factor inhibitors, and in all cases, every one of the inhibitors have really, some have shown very good promise early on in animal studies, but there has not really been any magic bullet to any inhibitor that has really worked very well. And this is one of the major realization that we are coming to. In fact, the Lancet Infectious Disease just commissioned recently a paper looking at the issues of sepsis and research, and the authors of this paper really delved greatly into all aspects of the treatment of sepsis and really came to the conclusion that so far that when we look at the history of it, we have not really had any inhibitor that has made one iota of difference. I'll pass it out to Ron.
Yeah, I agree with Tex. In fact, I have less of an opinion on this than Tex because I'm your average Joe clinician. I spend my time on the clinical floor rather than in the laboratory or charged with bringing in research grants. And as Texas said, this is too heterogeneous. We've looked over the years at many biomarkers, many opportunities to intervene in the immune pathway and the coagulation pathways, and time again, largely, I fear, because the population is so heterogeneous, we've seen equivocal results. And I think until we can fix this heterogeneity, until we can understand individual host response and the genetic response to sepsis, we're not going to see, in Texas terms, a magic bullet.
We can't hear you.
Keith, we've lost your voice at the moment.
Yeah, we've lost your voice, Keith.
Sorry, how's this? We're back? Good. This question, Ron, is for you. And it said, you spoke about new definitions for sepsis being used in hospitals and high-resource settings and how these may inhibit the early detection of sepsis in rural, low-resource settings. What are your thoughts and suggestions for rapid detection and antibiotic administration in low-resource settings?
Okay, so in settings outside hospitals, for the moment, considering primarily middle and higher income countries, what we need is the practitioners in those countries, and this is the same for people in low income countries, to know which patients to send to hospital. If there's a long transfer time, which patients need intervention prior to arrival at hospital. Now, the new definitions have been identified from a large database of 150,000 or so episodes. They've been assessed retrospectively to identify which parameters predict intensive care admission or death. Now, I would suggest that the practitioner outside hospital does not need to know which patient needs intensive care or is going to die. They need to know which patient needs intravenous antibiotics and which patient needs intravenous fluids and which patient needs transfer into hospital. My perception is that the cohort that's identified with the new definitions will be already very sick and that we will potentially be missing a number of people deteriorating with infection. So what they're going to need, in answer to your question, is an operational solution to the new definitions, perhaps, if you like, the identification of a cohort that is at interim level of sickness and some very clear guidelines. They're also going to need, of course, their public, the potential patients, to be aware of it so that they can access healthcare to start with.
Thanks, Ron. And that came from Catherine Majors. Thanks, Catherine, for that. Rupa Shilvers has this question. Do you know what analysis is undertaken for sepsis to know how much is based on unhygienic conditions as compared with STIs? It's hard to differentiate in both the cause of both, but if you have some thoughts into how we can do that, that would be appreciated. And that comes from Rupa Shilvers. I don't know, Tex, if you want to take that, or Ron?
You're saying that the proportion of cases are due to unhygienic conditions?
Yes, the question is what proportion, is there any analysis being undertaken to know to what degree unhygienic conditions contribute to sepsis versus having an infection under conditions of normal hygienic conditions?
Oh, that's a very, very good question, but we have no study to address that issue, mainly because when we look at the data across the world, we know that healthcare-associated infections are an enormous problem, especially in the developing world where you have large number of patients. There's very limited opportunities for hand hygiene. There's no barrier precautions, and there's sharing of equipment and bed, etc. So healthcare-associated infection is very high. The point is that beyond that, we know in our world also there are spread of infections within the hospital, and we try to decrease that with more resources and having barrier precautions. But the bottom line, the answer to the question is that we think it's an enormous problem, but there is no data or no study. And again, as Ron was mentioning, it is such a complex issue to determine the issue of the contribution of one factor versus another, that so many other factors play into it. For instance, in low and middle income country, there are going to be factors that play into it as the patient propensity to infection. For instance, malnutrition is a problem, the vaccination sort of issues, the issue of hygiene within the situation. So it's very difficult to tease out one, but we know it's a major issue that has to be dealt with.
Thanks very much. Thanks, Tex. We have about 7 minutes left, and this question is actually coming in various forms from a number of interveners: Michael Pollan, Robert Blightstone, and David Goldfarb. This question relates to antibiotic resistance, and I'll take Michael's. And it said, I'll hand this off to you, Ron. Michael asks, how do we manage the conflicting issues of global sepsis and global antibiotic resistance? Do they conflict directly, or is it more complex than that?
So I think it's more of a perceived conflict, really. And it's the way that the messages have been spun. We have, at the moment, two distinct messages. We have the very important antimicrobial resistance message, which is saying, well, it's demonizing antibiotics and demonizing antibiotic-seeking behavior. And that's quite right. We've got to address antibiotic-seeking behavior. We've got to address the low threshold for antimicrobial prescription. And of course, we've got to address antimicrobial use in agriculture, in veterinary medicine, and in farming. But then we have the message which can be perceived as conflicting, which is we've got to rapidly intervene in life-threatening infection. Of course, the messages are identical, really, and we need to start to work together. And that's what we're starting to try to do. So the Global Sepsis Alliance is linked with Compassion in World Farming, Antibiotic Action, and other organizations championing reductions in AMR, and is calling within our resolutions of the World Health Assembly, for example, to continue to improve strategies with AMR. By working together, we can get the right message across, which is we do need to preserve and develop new antibiotics for exactly this reason, because if you've got sepsis, you need an antibiotic quickly that's effective.
Great. Thanks, Ron. And Tex, I'm going to hand this one off to you, and it comes from Lindsay Boole. And Lindsay's referring to the Integrated Management of Health and Adolescent Illness. The WHO, as you know, puts out a district clinician manual. And Lindsay's question is, there's a very specific algorithm in the district clinician's manual for managing severe sepsis in low-resource settings. And Lindsay's question is, do you think that algorithm is the right one which to educate practitioners? And if so, should it be disseminated more widely?
I think that that's a very good question. What Lindsay is referring to is the integrated management of adolescent and adult diseases from the WHO. And it mimicked the IMCI, which is the Integrated Management of Childhood Illnesses. And what it does, it gives you a series of danger signs that point towards sepsis, recognizing in a low-resource setting that we do not have sophisticated laboratories to make diagnosis. So we make the diagnosis based on certain signs and symptoms, and it gives you an algorithm for treatment. Now, the algorithm for treatment that was given is really based on really some studies, but limited studies, but based on a consensus of opinion of experts. And I think it's a good starting point, because right now what we have is what we will call usual care. And usual care in mostly resource-limited settings would depend on individual practitioners' pattern of practice, etc. So what this IMAI gives you is a structured method of treating that really emphasizes early recognition, early management, as Ron was emphasizing, recognizing, giving fluids, giving some oxygen, giving antibiotics, and then as support is needed, given some low-dose inotropic agents. So I would say yes, that based on what we presently have, it is a very good mechanism that should be spread across. And the beauty of it is that it is very similar to the IMCI. And what I've suggested to colleagues is that because many of the patients come to the same emergency departments for treatment, that we train the individuals in both. Bear in mind also, however, as I said, it's expert opinion. And what we need, based on once it's instituted, is to then try and look at outcomes based on that, and then it will need some tinkering over time to improve it, rapid PDSA cycles. And we are trying to work with some of our colleagues in Uganda to really compare the algorithm of the IMAI algorithm to some tweaking a bit, such that we can sort of change the fluid regime, give less fluid where you do not have respiratory support, and introduce inotrope earlier. So the bottom line, yes, it's a very good advance that should be incorporated in low resource areas.
Great. Thank you, Tex. So we only have a couple of minutes left, and what I'd like to do, Ron and Tex, you're both the leaders of the Global Sepsis Alliance. Perhaps you could just share briefly what attendees can do to be able to support what both of you are involved in to get the public and professional constituency to support action to address this global challenge. So Ron, I'm going to hand off to you, and then Tex, why don't you conclude?
Sure.
In 60 seconds, how to affect change. I think it's about talking sepsis. It's about, if we receive a patient with sepsis, it's about telling them their diagnosis was sepsis, talking to their relatives about it. So educating the public for stage one. It's about interpreting the evidence that's out there, looking at the guidelines from the Surviving Sepsis Campaign and others, and operationalizing it for use. I would contest that simplified bundles. In the UK, we've promoted a very simplified bundle called the Sepsis 6, is the most effective thing you can do to affect large-scale change. Because a bundle that's produced in a critical care literature will not affect what's happening on a ward, on a floor, or in an emergency department. We need to translate it into something, well, sexy, really, something memorable. Then, if they want to affect change further, meet with the board, meet with the local politician, meet with the local media, celebrate evidence of success, get people who've been helped by your strategies to talk about your strategies, and start to share evidence, share data, share improvement charts, and celebrate.
Thank you, Ron. Tex?
Yeah, I think I agree with Ron. I think we have to start one at the grassroots. And from the point of view is that we have to educate families and parents about sepsis. And we have been doing that in some of the remotest areas in Bangladesh, for instance, and in Africa. And I think we start there. We also have to have a multi-pronged attack where we also try to educate kids in school. And I know we've had in Canada also the sort of kids, adolescents in school, mini-med school, etc., to get them understanding it, because as they've taken the lesson from the CPR, sort of American Heart, and sort of get it in the schools everywhere where the word is being mentioned. We also need to link with policymakers, administrators, and really use the word. And we also need strategic partnership with all our colleagues, because, as I said, sepsis belongs to no one, but it belongs to all. So we need to make strategic partnership with our infectious disease colleague, with our surgical colleagues across the board, and really make this an effort that comes off the lips of everyone. It should not be a few individuals. And ultimately, what we'd like to do is really get to those, the policymakers and the governments, that really would make a difference. So I think that I agree with Ron. We have to take it at every level. There's not going to be one sort of area that is going to make a difference. I think it's started with a very few dedicated people, but the only way that this is going to be successful, that we all realize that we all have a stake in this, we are all have something to contribute to decrease the burden of sepsis, to prevent sepsis, etc. And at the end of the day, we have to realize that we need to succeed, because we're all vulnerable to the very same thing.
Okay. On behalf of everybody here at the Consortium of Universities for Global Health, Dr. Kissoon and Dr. Daniels, I'd like to thank you very much for taking the time out of your busy schedules to talk about this global challenge. I'd also like to thank Karen Lamb, who puts and produces this webinar together. If you'd like to get involved in the Global Sepsis Alliance effort, please take a look at the Global Sepsis Alliance website. You'll find all of what you need to do and how you can participate, get involved, mobilize, and act. And if you'd like to get involved in the Consortium of Universities for Global Health, please look at our website at cugh.org. cugh.org. You can join, become a member, join our interest groups where you have a chance to share knowledge, to be able to participate, to be able to mobilize, to be able to build alliances, and to be able to act, to be able to improve the well-being of those around the world. Thank you very much for joining us at this CUGH webinar, and we look forward to seeing you next time.
Thank you, Keith.
Keith.
Thank you.
Thanks.